All right, good evening, everyone. Thank you so much for attending, and welcome to AUA 2025. Welcome to Las Vegas. It's great to have everybody here. We have a very content-heavy program tonight, but we really are going to enjoy your participation, and it's mostly all going to be through your phones. I'll go into a little bit more detail on that. Our title tonight is Personalizing Prostate Cancer Care, Real-World Approaches for the Community Urology Practice, because that's where the rubber hits the road, right, in community urology and oncology practices. We have folks that are, in addition to being here in the room, we have a lot of colleagues participating virtually, so thank you all for being part of the program. We would go back there. So, all right, so before I do anything, it's really important to introduce my colleagues here to my left, Dr. Eleni Estathiou and Dr. Steve Friedland, preeminent medical oncology, urology, who are not only have active, really clinical practices, but are on the cutting edge of many of the trials that we're going to talk about today. So, if you have questions, we want you to ask those questions, and you can type them in. We'll be having polling ARS questions throughout. So it's really great. And we're also very grateful to the folks from PeerView. This is a CME program. You get CME credit. You'll be able to apply for that. And then you love the patient advocacy group, Zero, as well as our industry sponsors who have had no input whatsoever on the content, inclusive of the ones I'm about to mention, but they're really great in allowing us to have these symposia here at AUA 2025. Astellas, Pfizer, Bayer, and Janssen. These educational grants allow us to have these opportunities for our colleagues. Please fill out the pre-event survey. As I said, we have in-room learners, we have virtual learners. I'll figure out how to do the clicker at some point.
It's used the other one.
That one.
Yeah,
Yeah, thank you. Thank you, Steve.
I know, why do we have that there?
All right, so
There's no clicker on the mouse.
this is fun, right? You're going to get, if you download this QR code, the virtual folks are going to get these questions. You need to please download the QR code, everybody, right now. And this is really important because you're going to get on your phone, you're going to get questions that pop up. The more questions you answer and the more questions you submit to us, allows you to win a gift card worth $50,000. $50, but there's going to be about $5,050 gift card. No, there's not. But somebody's going to win several people are going to win a $50 gift card. So we really want you to submit your questions about the content on advanced prostate cancer. After this is over, you can tell Eleni and Steve and myself tips on roulette and blackjack and all that stuff. We'll take your tips. So please scan the QR code, answer those questions. Really, really important. The pre-event survey and the post. That's really how we learn and we can do better. Peerview.com/prostate2025. You can get all the slides. You don't have to take any photos. You can download them all. And there were some really great practice aids by the folks from Zero. They have amazing educational information for patients and your nurses and your scribes and your medical assistants. They've got really great stuff. So our goals today are to look at the rationale and efficacy of existing data that really will support emerging systemic treatments. Look, we're urologists, we're surgeons, we're great at procedural things, but as we all know, we've moved into the era where we have to do both systemic therapies and localized treatments. And we want to equip you with some strategies and some tips and tricks and pearls to help you do that better. And it's a true multidisciplinary approach, and I think that's what's really great. Steve practices in academia, I'm in community. Eleni is a sort of a hybrid of both, and she's a medical oncologist. So I really appreciate that. So again, there's a question that should be coming to you right now as we get started. Please take a moment to answer a question about the challenges you experience in your practice. It's not going to come up. The answers are not going to come up. You're going to get it on your phone right now. The folks attending virtually, they're getting it on their screens. Please fill those out. And there's no time clock on that. Those will be persistent. But again, the more you fill out, the more questions you submit, the better you'll do in our lottery at the end for your $5 million gift card. Oh, sorry, I mean $50 gift card. Okay. So shared decision making, these are the factors that contribute to really high quality treatment decision making. Alicia Morgans, who we all work with and love her energy and passion for this, these are the things that come into play, the extent and the staging of the cancer, what patients want, what are their preference values, and then what are the treatments that are available, and then ultimately, what are you comfortable with? So these 4 factors really play significantly in making the treatment decision, and they differ. They differ for me, they differ for Steve and Eleni, and they're going to differ for you, but ultimately, we want our North Star is to do what's in the interest of the patient. Again, the shared decision making is supported by Zero. They have a lot of great tools on this and educational links and pamphlets, and I strongly encourage you to download these resources. They're all free and are very curated to be up to date with the latest level 1 evidence. So with that, it's a pleasure to have Dr. Friedland start on leveraging systemic therapies for high-risk localized. I'll talk on MHSPC, and Eleni will finish with CRPC.
Great. Thank you so much, Neil. And it's great to be here. Thank you all for coming in and spending a little bit of your time, not at the gambling tables, but listening to and learning about prostate cancer. So this is a study that was done years ago now, but it looked at patients who had a biochemical recurrence. And we're going to talk a lot about biochemical recurrence over the next 10 minutes or so, which is basically patients who've had surgery, radiation, and now the PSA is back. It's rising again. And one of the key factors that we look at is how quickly that PSA is going up. And that's what we call the PSA doubling time. How long does it take for the PSA to go from 1 to 2 to 4 to 8 to 16? And if that occurs less than 3 months, those doublings, what we can see here is the median survival for those patients in biochemical recurrence here at the 50% is actually about 6 years. So you often have these biochemical recurrent patients that are in practice for years and years and years, but not with the really short doubling times. Whereas if you have a really long doubling time, those patients do excellent, even out to 15 years and longer. And we can create tables that put in the doubling time, throw in some Gleason score, throw in how early they recurred, early or late, and you can actually generate tables that predict, and this is the historical data before all the modern intensification of hormones, before chemo, before all the different treatments that we have now, and you can see that particularly as we get to 15 years out, we can identify groups of patients that are highly unlikely to get to that 15-year group in the red there, and then we have groups in the upper left that do excellent with no treatment at all. So we really can start to risk stratify who's going to be in trouble. And the question is, for those patients that are high risk, that are likely to get in trouble, what can we do about it for those patients? And the first thing we can do is we can run trials to hopefully prevent recurrence in the first place. Because it's better than treating recurrence. Let's see if we can prevent recurrence. And so there's a number of trials, and we're going to go through these in a second in a little bit more detail, but a number of different trials looking either at surgically treated patients or more commonly radiation-treated patients, where we would typically add hormonal therapy, asking if we add intensified hormonal therapy, whether it be apalutamide, enzalutamide, or darolutamide, can we improve the outcomes for those patients? And for those that do get to the biochemical recurrence setting, we have a couple trials that we're going to talk about as well that have actually also tested, can we do intensified ADT to improve outcomes? And one of those, EMBARK, we're going to go into a little bit more detail because it actually has read out. It's now in the guidelines, and we're going to talk about that in a second. So the first is Proteus, which is the lone kind of surgical only trial here. And this is patients with essentially high risk prostate cancer undergoing radical prostatectomy. And we don't typically do hormonal therapy for those patients, but we have data that adding basic hormonal therapy doesn't worsen the outcome, so it's reasonable to do. And here the patients are randomized to ADT alone or ADT plus apalutamide, basically intensified hormonal therapy. They undergo surgery, and then they will continue with the treatment for another 6 months afterwards. And really the question is, can we delay the development of either metastasis or death as one of the key primary outcomes? We're also looking at pathological complete response rate, but really the registrational, the key endpoint here is, can we delay metastasis or death by adding a short course, a year of intensified hormonal therapy? And this study is still ongoing. We have a similar study called Atlas, looking at the radiation-treated patients, where we know adding hormonal therapy for 3 years typically improves long-term outcomes. And so if hormonal therapy improves outcomes relative to no hormonal therapy, intensified hormonal therapy by adding apalutamide should further improve outcomes. So this study is still ongoing. Hopefully we will have results in the near future. But again, this is based on apalutamide here for 2.5 years in that high-risk radiation cohort. And then we have the DAZZLE HiCap. So we have studies with apalutamide, and this is a daralutamide study. So these are patients getting primary radiation or early salvage radiation therapy. So all radiation, not all primary radiation, and they are randomized to ADT alone for 2 years, almost 2 years, versus intensified ADT, but this time adding daralutamide. And again, with the primary outcome of metastasis or death, which has actually been shown to be a surrogate for overall survival in early stage prostate cancer. That's why you'll see almost all these phase 3 trials are using metastasis-free survival as a primary outcome, because it is a surrogate of overall survival and accepted by the FDA as a registrational endpoint. And we have EMBARK, which again has read out, and this was again in the biochemical recurrence space, but focused on those high-risk biochemical recurrence, defined as a PSA doubling time less than 9 months, and conventional imaging negative. So no CT or bone scan evidence of metastatic spread, and the control arm, if you will, was ADT alone, kind of standard, what we've been doing for biochemical recurrence for many, many years. And again, asking whether intensified ADT, adding enzalutamide, improves outcomes, or actually for the first time ever in a phase 3 trial, whether enzalutamide by itself can actually improve outcomes. So are these drugs now that we have, these modern androgen receptor pathway inhibitors, so potent that we don't even need the ADT anymore? Treatment was suspended at 37 weeks if the patient had a really good PSA response, and then was reinitiated when they hit certain thresholds, and then they would stay on treatment. It wasn't true intermittent, but there was one off-treatment cycle. And as you see there, obviously it was a positive study, approved by the FDA in November of 2023, and now in the guidelines. And these are the data that led to that here. This is the primary outcome. Again, metastasis-free survival, which is metastasis or death. And you could see by adding enzalutamide to the ADT, you have a hazard ratio of 0.42, meaning adding enzalutamide reduced the risk of metastasis or death by 58%. Really dramatic statistical significance, clinically significant, and on an interim analysis, suggestively improved overall survival by a reduction of 41% reduced risk of death. And we are waiting for updated survival data, which hopefully we'll be able to report to you soon. But then the question is, do you even need the ADT? What about enzalutamide alone? And that also delayed metastasis or death relative to ADT alone, with a 37% reduction in the risk of metastasis or death, with interim analysis for overall survival, immature data, but still also trending in terms of improvement. how about the side effects? This is great, we get the cancer benefits, but what about those side effects? So if we look here, the enzalutamide combination on the top relative to the ADT alone on the bottom, whether you go look across the board, you see a little bit more side effects with combination therapy, which makes sense. It's better ADT, so therefore any ADT-related side effect, you're going to see a little bit more of. The monotherapy, enzalutamide alone, being the interesting one, never been studied in a phase 3 trial before, and because you're not castrate, you have lots of testosterone floating around, which gets converted to estrogen, and so estrogen is going to go to the brain. Say you got plenty of hormones, you don't need to have hot flashes, so we see relatively low hot flashes, but that estrogen is going to go to the breasts and start causing the breasts to grow. So you see a lot of gynecomastia. We think that can be prevented with radiation before you start the enzalutamide and or tamoxifen. Generally 10, 20 milligrams, anywhere from every other day to daily seems to work. But it's something we need to be very mindful of. We do see breast-related side effects on the monotherapy. We also looked at patient-reported outcomes, and basically these are asymptomatic patients, right? They're biochemical recurrence, they have no metastatic disease, so we're not going to improve the quality of life, but if we can maintain the quality of life, that would be a big win given the cancer benefits. So as patients age, as time goes on, they're all on therapy, we expect the quality of life to go down a little bit. And the question is, how did that differ if you were on enzalutamide combination on the top or monotherapy on the bottom? And so we looked at the time to confirmed deterioration in quality of life. We highlight the ones that are statistically significant in the boxes. And the first important thing is we don't see a lot of boxes. That we really overall, in general, are preserving the quality of life of these patients. We do see a little bit more hormonal treatment-related symptoms with combo. Makes sense, it's better ADT. I'd expect to see more hormone treatment side effects. But really important with monotherapy, we see better preserved sexual activity. And obviously for patients, these are post-surgery, post-radiation, and they're not all sexually active. But for those that are, that's a really significant clinical benefit for our patients that we can better preserve that with monotherapy. About the treatment suspension, the vast majority get treatment suspension on enzalutamide, less so with ADT. In fact, a third of patients on ADT alone never got that treatment suspension. And it lasts longer on combination than ADT. Monotherapy, it lasts the least, but remember, the minute you stop treatment, they have normal testosterone. So they're getting 11 months of normal testosterone unopposed. So if you actually look at the time to testosterone recovery, they're actually getting relatively similar lengths of time with normal testosterone across all three groups. There are other trials. There's a darolutamide monotherapy in patients with biochemical recurrence. And what you see is relative to what we saw in EMBARK, a little bit less testosterone elevation, and you still see some very good PSA responses, less than 0.2 here, over 65% at week 12. In EMBARK, we looked at week 36, not week 12, so the numbers I think are a little bit better. Be interesting to see with a little bit longer follow-up what we see in terms of at week 36 here. But again, a phase 2 trial, but also showing efficacy from RP monotherapy. And then there is the ARISTEP trial. So this is biochemical recurrence, high risk, defined as doubling time less than 12 months, but the PSMA positive patients. So traditional imaging negative on conventional imaging, but PSMA positive, where you say, look, it's metastatic disease, I want to start hormones, but we don't quite have that level 1 evidence that Neil's going to talk to us later about in the metastatic space. So asking, can we apply that in this space here with darolutamide and 2 years of treatment and then long-term outcomes, looking at radiographic progression free, but obviously metastasis-free survival by conventional being a key secondary outcome of this ongoing study. So Alicia Morgans, we talked about her earlier, presented some really interesting data at GU-ASCO, and this is basically a chart review looking at patients with high-risk biochemical recurrence, and basically asking the question, the doctor who reviewed their own charts, could you tell us the patient's doubling time or not? And if the physician knew the patient's doubling time and can put it in the case report forms, what we saw is that patients were much more likely to get aggressive treatment. They're all high risk, and BARC data said they should get it, but if the doctor couldn't even tell us the doubling time, that's the PSA doubling time, unknown PSA doubling time, much, much less aggressive treatment patterns. Really saying we know PSA doubling time is super important as a prognostic factor, but yet there's about 60% of the charts, physician didn't even know their patient's doubling time. Just shows how valuable it is to calculate it, document in the chart, and then act upon it. And on that note, we have a couple cases. I'm going to turn it back to you, Neil.
So fantastic. A quick question. We're getting questions that are coming in, so thank you all. The Proteus trial, they're asking any idea when there would be a anticipated readout on that? That trial has fully accrued. Any thoughts on that, anyone?
Same as yours. We're all waiting impatiently.
Yeah, right.
We're
It's
waiting,
a huge
hopefully
trial,
soon.
right?
Yeah,
Huge
hopefully
trial.
soon. Yeah, that's a great question. It's an important study, a huge study, more than 2,000 patients, neoadjuvant, adjuvant. Now we're maybe sometimes calling it perioperative. But we don't have any neoadjuvant, adjuvant studies in high-risk RP patients. That's why I think this Proteus trial is particularly important. Another quick question here. Steve, I'll throw this one over to you. What PSA level, and it's a little bit of an interesting question, would, under a thorough watchful waiting protocol of a 67-year-old ECOG 0 healthy patient, but a significant family history of prostate cancer and, say, other cancers, how do you think about that patient in terms of doing a biopsy?
So this is someone not yet with prostate cancer?
Correct.
Yeah. So it's a great question, and you know, I'm much more comfortable nowadays watching PSA. I think we use PSA density a lot, you know, if they have a real big, juicy prostate, and that's why I love getting an MRI, because not only does it tell me is there lesions, PIRADS 4 or 5, but I get a really accurate prostate size. And so if the PSA density is low, traditionally below 0.15, I'd love to see it even lower. Don't think they need a biopsy. But if you're getting PSA densities above 0.15, above 0.2, certainly, I do think there's a biopsy necessary. And if you're in doubt, there are other biomarkers that we could certainly use.
Yeah, so are you using biomarkers? And there's AI now, there's urine-based, there's serum-based, there's a lot out there.
There's a lot of them. My personal preference is exosome test, and I think they all perform similarly. To me, it's a logistics issue. I can email my nurse and say, Mr. Jones needs an exosome. She reaches out to the company reaches out to the patient, they send him a kit, he pees into the cup at home, he sends it back. Next thing you know, I get the results. So all I have to do is send one email to my nurse, I wait a few weeks, and I get a result.
Yeah.
I don't need to see the patient, I don't need to do a DRE, it's just logistically simple.
Yeah, no, that's great. I mean, there are multiple urine-based tests. There's the exosome, there's the select MDX test. You know, learn about these, and then you also have a lot of blood-based tests. There's so many of them that are out there. I think it's about getting comfortable with them when you want to use them is the point. And MR for sure, high-frequency ultrasound, and even on some, and the PSA density, I think is really a good fit. So let's look at these quick cases here. So we have Alex, a 65-year-old, you know, let's say great health, PSA doubling time at 10 months, and BARC, you know, basically had a 9-month EAU, says less than 12 months for their high risk. So there are some, he's concerned about cancer recurrence. Let's say, you know, he underwent previously an intervention, maybe it was an RP or an RT, and he's now a conventional imaging negative, and the PSMA PET comes back equivocal. But the doubling time, Steve. So how do you advise that patient?
Yeah, I mean, I think when we look at prognostic factors, it's clear that doubling time is probably the most important factor. And, I think about watching runners run a race. And, if I know how fast you're running and I know where you are in that race, I can predict where you're going to be tomorrow. And so doubling time is how fast it's running, but you also throw in PSAs. Is he at brand new recurrence of 0.2? Or have I been watching him for years and now his PSA is 10? Yep. I think it's going to make a huge difference. Are there other risk factors? Seminal vesicle invasion, Gleason 10, he recurred early. Or is this guy that's been slowly smoldering along? What's his life expectancy? Probably we don't know anything about his comorbidities. Did he have an MI and he's on oxygen?
Yep.
You see, or is he completely healthy and just ran a marathon yesterday? All of that's going to play into it.
And I think it's purposely put the PSMA PET as equivocal because there is inter-observer and a lot of different reportings on PET. We're learning a lot with that, and I think everybody has to rely on their local reads, and that's very important. Eleni, this last case, just a quick thoughts. Martin, he's 78 years old, so he's older than Alex. Clearly, he's got a doubling time of 6 months. And Steve showed you those really nice tables that were really, predictive of life expectancy, prostate cancer-specific mortality. He had previously experienced really in some level of intolerability. I'm assuming he had ADT and radiation. He's now recurred. He's a BCR. And, we see patients like this, some who say, hey, I wasn't bothered by the ADT, and some who were just absolutely miserable and don't want to go back to it again. How would you treat this patient? How would you counsel him?
Yeah, this is a very everyday case, I would say. We see it in the clinic all the time. Patient comes in, PSA now is going up rapidly. Let's assume a low number, right? But patients are getting worried, around 1, 2, sometimes even less. We do our PET scan. We will do it, right? And we'll do an MRI of the prostate bed, let's assume, or if there is a prostate. And let's assume we don't see anything, but still you got that doubling time. And it's very stressful for the patient. We have a discussion over the EMBARK data. We do. And I can tell you these days, it's half and half. I use a lot of the oral LHRH antagonists, as we've discussed. And sometimes we say, okay, let's go for both and see if you can tolerate it. Because it's a pill, we can ditch it. We can leave it alone. We don't fire us yet, I usually tell the patient. Just wait for a little while. Other times, especially in the older gentlemen, the ones over 80, we say, let's do monotherapy. And it has worked very, very well. I mean, the cases that I've seen, rarely do I see not reaching an undetectable PSA. In fact, in some cases, we've done these 9, 10 months, stopped, took a break, and then restarted like a year later. It's been a blessing having that monotherapy, very well tolerated.
Yeah, I concur. I think it just adds to our, our proverbial toolbox, the armamentarium, to say patients now have choice. And, you can, it gives some flexibility. So that was excellent, Steve. Thank you so much. Again, please take a moment to answer a follow-up question. That's like super important, and we'll get you to the winning ticket. Okay, so thanks for doing that. So now I'm going to talk about navigating therapeutic choices in MHSPC. I'm going to assume that many of these studies you've heard about, but so I'll go over them a little bit quickly. The volume of disease at presentation and how one presents. You see the cartoon pictorial here of how we describe high volume versus low volume. Low volume is typically going to be on nodal tissue only, no visceral metastases. High volume has liver or lung lesions and or 4 or more bone lesions on conventional imaging. And then there's the oligometastatic group, which is what, how we define oligo, Greek for few. Correct me if I'm wrong on that. It can be, typically, a lot of people are saying few, oligo is less than 5 or less than 3. It's a bit subjective. But the key to the graph to the right is basically telling you that if you have recurrent or metachronous low volume, those patients do best in terms of survival. The ones who do worse are the synchronous or the de novo high volume. And so we really need to be thinking about that with our patients. Their biologies will vary, and so that's something that I frequently describe to patients so I can help them figure out their level of intensification. So the timeline for the combinations, this is a really wonderful slide in so many ways because I think it speaks to many of us who've been involved in trials. In the last 10 years, or if you think back to 2004, where we had the approval, 20 years ago, the approval of docetaxel, the first life-prolonging therapy in MCRPC. Fast forward now 20 years later, and we have north of 12 therapies that are approved for advanced prostate cancer. So we're making progress, but metastatic prostate cancer is still, for most patients, can be a terminal disease. So the strides, we're doing well. If you look at the boxes here, the blue box is the monotherapy. I'm going right to that, because that's where, I think it's fair to say, even though we had all this level 1 evidence that I'm going to show you in a matter of seconds, and we started off with great studies with, Charted and Latitude for abiraterone and Arches for enzalutamide and Titan for apalutamide and now Aranote for darolutamide. Unfortunately, so many patients, this is US data, we're still getting monotherapy ADT, which I think should be relegated to a single-digit percentage of patients. I'll put that out there. And contemporaneously, we still see about a third of patients still getting monotherapy ADT. The ADT docetaxel, the orange box, you see that diminishing, but what you really see dramatically increasing is the gray box, is the ADT and an ARPI, an androgen receptor pathway inhibitor. And I think that that's really great. And then even the triplet, for those who have high volume, who say, I want to be as aggressive as possible, I'm not risk averse, I'm really fit for chemotherapy, I have high volume disease, so I want to do a triplet therapy. You see that increasing as well. This reviews all these really amazing level 1 studies that have led to a change and movement away from monotherapy ADT, moving away from, on all respect, to our Huggins and Hodges, who got a Nobel Prize in 1966. But we have moved away from that. We have made really great advances. Here's a quick review of the Kaplan-Meiers of these groundbreaking studies. Titan for apalutamide, Arches for enzalutamide. We're actually going to be reporting 5-year data for the Arches overall survival at ASCO this year, so stay tuned to that. Others have reported 3- and 4-year data, Titan. Abiraterone, I think they have a report out as to 3 years as well. So what are the lessons that we've learned from doublet trials? Whether it's progression-free survival or overall survival, clearly, unequivocally, besting superior to monotherapy ADT. And for the most part, quality of life is maintained or even improved, especially the patients in ADT. When you add another therapy to one existing therapy, you could say, oh, well, I'm going to increase the toxicity. But what gets balanced off is the lack of progression, and that helps those patients with their quality of life. And what about triplet therapy? So the first triplet therapy, kudos to most of the work being done in Europe, and Karim Fazazi presented this and published it in Lancet, was essentially by adding ADT docetaxel and adding abiraterone, we see this marked improvement in these patients and very good tolerability. Next came the Arisons trial, which was actually designed before the Aramis, the NMCRPC trial, had even completed. And kudos to the folks at Bayer for being very aggressive. They took a triplet approach, ADT docetaxel, the docetaxel invariably in piece 1, and Arisons was just 6 infusions, so it's over in about 4 months. Patients are younger than our MCRPC population. They tend to be better performance status. They tolerate overall very well the increased grade 3, 4 AEs that you can see with docetaxel, myelosuppression, some GI, alopecia. But these are the patients really tolerate it, much better than our older MCRPC patients. And the bottom line was this triplet bested the comparator ADT and docetaxel. So then we have ARANOTE that just reported out in September at ESMO, and this was presented by Fred Saad, and this was another really nicely performed MHSPC study, not done in the US because of the equipoise concerns with all the doublets that were already available. They took patients and said, okay, you get darolutamide, the 600 milligram BID plus ADT, and blinded to a placebo control of ADT in this patient population, a 2-to-1 randomization. We have data that we're presenting here looking at ultra-low PSA estimations, not only the less than 0.2, but the less than 0.02. Other studies have done the same, and it's a very compelling data, and I recommend you take a look at that. But this was a successful study, as you can see here, a hazard ratio of 0.54. This just came out, and it's so new, it's not really into the guidelines yet. It's published in JCO. The subgroup analysis, whether it was high volume or low volume, you see the benefit for the combination. So once again, the importance of not using monotherapy ADT. We have a 200-patient study that we're doing in the US, fully accrued, called ARASEC, and we'll do a match-adjusted independent control to the monotherapy arm from CHART, the monotherapy ADT arm, which I think was a really nice aspect of the FDA saying, okay, we want to make that as a compendium for review when you come back with the ARANOTE trial, which was conducted outside of the US. Here's a really interesting, I think this is a great study. This is the Libertas study. It's a little bit, you can see some of the schema up here, but bottom line is these are patients who are newly diagnosed, MHSPC, low volume, high volume, good performance status, and essentially they'll get ADT and apalutamide, the approved dose. And then if they get to a PSA that's less than 0.2, then they get randomized to 2 different arms. If it's undetectable, then they can go to continue the standard of care. And then if they're, if they're above 0.2, the standard of care as to what the patient and clinician want to do. And if they get that really markedly decreased PSA, then they get randomized to intermittent APA and ADT versus continuous. I think this is kind of the thing that maybe Steve was alluding to earlier, at least in the BCR population and BARC, we only had 1 treatment interruption. So here will be an opportunity to look at that. And here's some early data looking at the PSA change at 6 months from baseline. It was rather very impressive. So when you're making the decision between doublet versus triplet in a healthy patient with good performance, this isn't completely an exhaustive list, but these are some of the things that I think we think about is, the different AEs that are associated or the different monitoring with the already approved therapies, whether it's abiraterone or enzalutamide or apalutamide or darolutamide. Is pill burden an issue? And then other things. And this is not an exhaustive list, but this is where I encourage you to make sure that you're up to speed and understanding the nuanced differences. Sometimes it's really good to also appreciate any drug-drug interactions as well. So let me stop with that. And okay, so we have a case here. We'll ask our panel. So here's George. He's 68, and he has a recent onset of diffuse bone pain. And his PSA is 2025. Whoa, that's why I put that in there, because here's where we are today. It's 2025. So he has a sky-high PSA. He's got bone pain. He gets biopsied, and lo and behold, every single core. So he's grade group 5 disease. He's Gleason 8 and 9. Otherwise, he's just having the bone pain. So many of these patients get missed, right? They see their primary care physicians. They, oh, you just have back pain, and we'll prescribe an NSAID for you. But they catches the PSA along with everything else, probably his alk phos is sky high too. CT, conventional imaging, shows extensive bone disease, no visceral disease, and he's got lymph nodes in the pelvic and the retroperitoneal space. The bone scan's got greater than 20 lesions. It's like a super scan. All right, so Eleni, how do you think about this patient?
Well, I'm going to up the risk here and say he's the kind of person who's walked in, and he also reports having lost weight. It's kind of constitutional symptoms, not just the bone pain. Because one could argue he's got a very androgen signaling driven disease, you could give a doublet. Usually this kind of gentleman is going to come in, report that depletion, the fatigue, not having an appetite, like that cytokine storm of the disease. That's when we talk about a triplet. That's where I would bring it up. If he has liver mets as well or other visceral mets, no question. But he would be the kind of person that I would have the discussion over a triplet. He might pull back and say, chemo, no. So then we would go on our doublet and consider.
But you'd give him the shared decision-making, and I do as well.
Absolutely.
Steve, would you order a germline in this patient? Or even a somatic testing? How do you think about that for our urology?
Yeah, no, it's a great question. I mean, absolutely yes. I mean, these are patients, anyone with metastatic disease needs testing for homologous recombination deficiency. We know later in the disease stage that PARP inhibitors have significant clinical benefit. We're looking, and there's trials ongoing, testing it earlier, such as at this stage. But if he has it, it certainly has implications for other family members. It's prognostic. So absolutely, again, anyone with metastatic disease needs good testing.
Yeah. So we presented an oral presentation today on MHSPC patients over a 5-year period from like 2018 to 23. Just this morning, we presented it. Dan Lin was the first author. And essentially, looking at a cohort of about 4,000 U.S. patients, only about 20% got germline testing. But of that group, when they looked at the ones who were BRCA versus HR positive versus those who weren't, there was a marked difference, statistically significant, retrospective, real-world study, a clear difference in the time to next treatment and also the time to castration-resistant disease. So I think this is the kind of data and why it's so important. The BRCA patients did much worse. Okay, Steve, now you have Nathan. He's 56, he's asymptomatic. He presents, he gets a PSA screen. You know, many PCPs are not getting it, more and more are getting it now. But he has a PSA at 24, he's biopsied, and he's grade group 3, 8 to 12 cores bilateral. He's an avid golfer. He's completely like, what? Hey, how could this happen? You know, he goes for a PSMA PET. This has become really almost standard throughout all facilities where you can get it. And he basically just has some borderline, you know, SUV activity, but in the chest and the pelvic region. Nothing bone, nothing visceral. What do you tell him?
So this is an interesting case because if we did conventional imaging, CT and bone scan, he would be negative. And he would be typical surgery, radiation. We'd have a long discussion, 56, more likely to end up choosing surgery, but radiation would be a very reasonable option as well. But when you throw in the PSMA positive, you know, the question is this really metastatic disease? How do we manage the metastatic disease? Is it worth treating the prostate in light of this possible metastatic disease? And the honest answer is we just don't have level 1 evidence.
Yep.
So I could tell you my thoughts, but again, it's just to be clear, we do not have good evidence as to what to do. For me, I would be, you know, asking the question, can we radiate those metastatic sites? And he's young, he's healthy, and he has bad disease. So to me, for someone like that, I want to be aggressive.
Yeah.
Even in the absence of perfect data, I want to be aggressive. Let's radiate that. Let's treat the prostate, surgery or radiation, probably throwing in a course 6-12 months of systemic therapy, probably with an RP. Again, just making stuff up as I go, and hope we have a good outcome.
Yeah, no, and he's sort of an Aristep patient. You showed that. So he's basically, you can radiate the primary, radiate the lesions, and in Aristep, they're getting randomized to 2 years of Daro and ADT versus Daro alone, versus ADT alone. Okay, fantastic.
And he's getting germline testing too.
Oh, he's definitely. Thank
Too
you.
young. He's like 50.
Got to get germline testing. Got to get germline. Okay. So answer this question on your device. Our virtual folks are seeing this on their screen. Please answer this. And our next, but most and best presenter is going to be Eleni Estathio.
Okay, so that's like the movies that you prepare people, that's going to be a good one. That's a flop. First of all, thank you everyone for being here. I mean, it's surreal. We're in Vegas.
Yeah.
It's like Medonk, never do that. That's why we go to Orlando, because, it's like I just walked to a convention center through a casino. It's like, so I was tasked to talk about castration-resistant prostate cancer, and this is a here group of friends. We've worked together, collaborators, and it's great to be here. But I'm not going to bore you down with everything that's happened in CRPC, because this is where all the development starts, right? So let's talk a little bit about what has happened in the course of these 10, 15 years. And we decided to put up here some data that we just presented at GU ASCO, where we sat down with a Flatiron team. They have this big database, and we took patients who had between 2018 and 2022, we didn't go all the way to now, CRPC. Why? Because we wanted to see what happened before and what happened after. And again, when they were with CRPC in 2018 or 2022, up to then, they had been diagnosed earlier, right? It could have been anywhere from 2010 or before to 2017. So you can see the trends, right? And you mentioned it earlier. We're starting to move earlier with the androgen receptor pathway inhibitors, which is a good thing. But the one thing that really didn't change is we're still, and this is not a criticism, we're going from one AR pathway inhibitor to the other. And we've seen through doing a lot of trials, that's not really always the best way to go. It's about 20 to 30% of patients who will get a benefit if you go from one to the other, and there are 4 out there. I would say, and we can talk about it more, that it will be mainly the patient who has really done well for years on the one, and maybe then you want to change to the other one to give him a second chance. And I'll talk about a trial that gives us some other opportunities. The other thing that's not on this slide, we need to keep in mind, and this is coming from an anti-chemotherapist here, is we're losing a little bit the use of chemotherapy, mainly because we're getting excited by the other drugs. But I want to fall back on what you presented. There is something to be said about using chemotherapy when you have a really aggressive disease. And we don't have yet the biomarkers to identify that, but you see it in the patient that comes really symptomatic through the door. So let's fall back. It's going to be 2 groups of drugs or mechanisms of actions that I will speak about to not make it too lengthy. One is going to be radioligands. The other one is going to be PARP inhibitors, right? Radioligands, it's not a new story. It's an old story. And the first time we actually showed a survival benefit, it's already about 12 years old with radium-223. That was the Alsimca trial. It was a while back. It was a single study that gave the FDA approval to radium-223. But that was the interesting part about this trial. It showed the overall survival benefit, but we didn't see PSAs drop. We didn't see the rPFS. And I think in our consciousness, it was never that strong drug that you would use like immediately in CRPC, even though it was tested for patients who did not even have chemo before. So after that, some of you may remember a trial we tried to do where we took abiraterone, which is what we had, and combined it with this drug versus abiraterone alone, again in the CRPC space. That trial was stopped. Why? Because we were dumb, and we were treating patients without taking care of their bone densities. And we were hitting them with drugs that affected bone densities, so we caused osteoporotic fractures. So we had to shut down. But we learned from that trial. And this brings us to piece 3. You mentioned piece 1. It's from the same group. It's European. And it accrued patients who had castration-resistant prostate cancer and essentially had not been exposed to androgen receptor pathway inhibitors. So they were CRPC, they had not been exposed, and the patients were randomized to receive enzalutamide versus enzalutamide plus radium-223, which was very risky because we know that androgen receptor pathways inhibitors have never failed in any of the trials that we've done. And all of a sudden, we're throwing a drug in that didn't ever prove to have anything on PSA decline or rPFS. We have some survival data. But as we learned, as this trial was going on in accrual, we learned from the other trial that was shut down, and we made patients who were being recruited get on bisphosphonates or other bone-modifying agents such as denosumab. So we had that covered. And you can see here over time, as patients who were getting on this more recent P3 trial were being made to be treated with bone-modifying agents, and you can see that bottom line, how we reduced the risk of fractures. So very important thing to consider during your everyday practice. I make everyone, even my 60-year-olds, have a bone density scan. It helps that their wife is there with them and she already has had one. So they kind of like, because primary care physicians are not going to do it. The other thing that came through for the trial, and it kind of totally threw me off, I'll be honest, I didn't use radium-223 before this trial, was like, all of a sudden, we're seeing radiographic progression-free survival benefit in the combo of Enza with radium-223 versus Enza alone. It kind of blows your mind because radium-223 alone did not show that. It's the combo. It alludes that there's some kind of synergy. And I'll give you one more. It showed overall survival benefit. I did not expect that. And this is a very humbling moment when you see this data and you're like, I had it wrong. I don't know how many times I've done that. It's like almost too many. So there's other trials. And of course, all of you are thinking, well, what are we going to do with radium-223, right? These patients are coming in the door having had Enza or Abi or Dara or APA. Well, it kind of raises the question, if there's an oligoprogression or it's only bone disease, should I throw it in there and keep the Enza or just switch there? Things to think in your everyday practice, which I do now. Now, there are other trials that are going to be reporting and might reinforce that signal. There's particularly one that I'm familiar with. It's the combo of docetaxel with radium-223 versus docetaxel alone. I anticipate that to be more toxic, but let's wait to see what the results will show us. Now, let's go to the sexy part of things. PSMA-targeted radioligand therapy. There's a lot going on in that space. You're all familiar with the VISION trial. The VISION trial was the first one to show that PSMA targeting with lutetium PSMA 617 in those patients who had been exposed to enhanced androgen signal inhibition, had received chemotherapy, and were randomized to get lutetium PSMA plus standard of care for that patient versus standard of care, but not chemo, it really showed that there was an rPFS benefit, there was an OS benefit, all secondary endpoints were met. One important consideration here, these patients had to have a positive PSMA PET. And on top of it, after this trial was reported, we kind of went into the nitty-gritty details and we found more information that was reported a couple of years ago that showed that these men that had a higher SUV expression on that PET did even better, kind of giving us more tips as to how to move forward with these patients. It became a very, very attractive option for patients because it was well tolerated. But if you recall, at first we didn't have access. Now there's more access and more patients are requesting it. On top of it, we got some newer data recently in those patients who have not been exposed to docetaxel, so pre-chemo, again, CRBC space. Now this time, we compared PSMA lutetium, again in patients who had PSMA avidity on the PETs, versus switching, right? The one thing that I criticized earlier. But as I mentioned, it's a common practice. We do it all the time. So it was something that the FDA accepted as a standard of care. Importantly, and ethically so, patients who progressed were allowed to cross over. So a lot of patients who went on that switch side were able to get lutetium PSMA later. And this trial met the primary endpoint, which again was difference in progression-free survival. It hasn't yet shown overall survival benefit, but we recently heard from the FDA that now we can use this agent earlier pre-chemotherapy, and a lot of us are actually using it. Interestingly, as I was flying over, I was watching, at my baseball Astros play, and they did well today. So they had a lot of ads on this agent, and it was very detailed for patient advocacy part, talking about how it differs from chemotherapy. I was actually excited to see that. Now, there's a lot more going on, right? PSMA targeting, other radioligands, we'll hear more and more data coming forth. Now, let's talk about the part that we already covered. And this is your data again, right? You looked at patients, looked about 1,000 patients in the US, how much they had been exposed to HRR testing, and you showed that, you say only, but I think 60% at that CRPC space is a pretty good number. We're getting better and better. Now, the problem becomes that question of no patient left behind, right? So from that 60% of patients who actually received HRR testing, only 2/3 of them went on to receive PARP inhibitor treatment for many reasons, possibly. So if you do the math, there are patients left behind, and we need to do better. And again, this is not a criticism, because the administrative burden for doing this testing, the complexity of understanding and explaining to the patients, needs a lot of work towards more and more education and support, importantly. There are 3 available combinations of PARP inhibitors with ARPIs: olaparib plus abi, niraparib plus abi, talazoparib plus enza. We don't cross-combine because we don't have safety data. That's all we can do. And the approvals that we have by the FDA in the US is for CRPC patients. The first 2, only BRCA mutated. The last one, for HRR mutated, talazoparib plus enza. That might change, we'll see, but that's what we've got for now. The rest of the world a little bit different, because the trials were designed, at least the first and the last, for all comers, and has shown benefit in all comers. But this is the data that applies to our FDA approval for PROPEL, which is abiraterone plus olaparib, has shown an rPFS benefit and OS benefit for BRCA mutated patients. I would say also for HRRM, but because of the design of the trial, it didn't really make it through that threshold. Magnitude trial, totally, and I was very involved with this trial, totally different design, really focused on HRR positivity and BRCA positivity, and that was the goal, and it got the approval for the combo. And finally, TALAPRO-2 trial, the trial that really has given us more data recently to support. This is the data that you're seeing here, the final analysis of overall survival. It's the second iteration. We got initially an rPFS benefit for all HRR mutated tumors. We now got an overall survival benefit, but we did not include here the slide that includes the overall survival for all patients. It's a very convoluted matter. I'm thinking we might hear some new information as to whether we will have access for all patients. It's a big discussion, but more to come. But let's talk about the roadblock with PARP inhibitors. The roadblock is toxicity, right? That's what it is. Otherwise, we would be more open to using it probably for all comers if it was approved. The hematologic toxicity is coming from the fact that they are not just PARP1 inhibitors, they are PARP1/2 inhibitors. And as some of you may know, we are now in the process of testing PARP1 inhibitors, and those of us who use them in trials can tell you it looks like it's safer, but it has to prove that it is as efficacious. So that's the next step. And let's look at what I'm talking about. If you look at the top of this table, the anemia is a problem. Look at that TALAPRO-2 cohort. About 40% of patients will experience an anemia that will require transfusion, which is obviously taxing for patient and practice. But the good thing is you know early on. Within 2-3 months, you'll know about it. The same applies, of course, for the rest of the toxicity. In my practice, the most common concern is the fatigue. Now, I'm going to finish up by bringing up this very important consideration of genomic testing. It's not just for this patient, it's about saving lives of other people. Back in the day where we were, because these guidelines have been around since 2017, but a lot of institutions were resistant. And my previous institution was initially quite resistant. I will never forget the fact that this 56-year-old man of Jewish descent who ended up being proven to have a BRCA2 mutation was not offered because of roadblocks in administration early on his germline testing. Well, by the time we figured it out, his daughter already had metastatic breast cancer at the age of 35. So I don't think I will ever forget that. And for that reason, probably, I go above and beyond doing this genomic testing and trying to educate everyone in the group, others, and our patients. So I will stop here, I think.
Yep.
But before that, just actually, we're waiting for data. Like you said, we might hear this June using these PARP inhibitors early on in the hormone-sensitive prostate cancer space, so it might become part of your practice. So I think we need all to be catching up.
Yeah, that was great. You have another QR code to get some answers and feedback from you. Really, really great that we're able to start to combine, and help patients live longer. Obviously, goals, keep them out of the emergency department, keep them from being hospitalized. Here's a question, and it's kind of basic, but it's kind of interesting in a practical way, and I like it. It's, Eleni, when can we stop ADT in an MCRPC patient? Do you check, what do you do about that testosterone level? They've been on ADT, let's say, for, many years now. Do you keep that going outside? It's not a clinical trial.
It's a shared decision making. The other day, I was having one of our telemedicines with my 85-year-old patient who has had it gets even more than that. He had been on Lupron for 5 years, and we decided to stop it. But as you know better than me, that testosterone is not coming back up. The patient has an undetectable PSA. Well, I took it a step further, and we both decided mutually that we're going to try some oral testosterone. And it comes to that because he's having a crappy, I apologize, quality of life. He is suffering from osteoporosis. He is not happy. So we do make these decisions in some cases. And if we fall back on hormone-sensitive prostate cancer, like the case we discussed earlier, I take it to 2 years, even in metastatic, and if the patient seems to be no evidence of disease, we try it, as long as we monitor carefully.
Yep. Great. Okay. So we have 2 quick cases here. I know we're pushing up on time. Adam Young, he's 62, he's asymptomatic, he has MCRPC. He got there through monotherapy ADT, may have failed his prostatectomy. And now he comes in after maybe having a good response on ADT with PSA nadir, but now his PSA is going up, he's asymptomatic, and he has 4 bone lesions, maybe a couple of small bone lesions. Let's say it's confirmed on technetium bone scan and maybe PSMA PET, maybe 2 in the spine, 1 in the rib, maybe there's something in the femur. How do you talk to this patient, Steve? You did his prostatectomy, he had a rapid doubling time, had to get on, he didn't want to do the ARPI, or maybe you inherited him at Cedars, they came to see you, now as a second opinion. How do you dialogue with him?
Yeah, no, it's an all too common situation. We still see patients with metastatic CRPC who are relatively treatment naive, and certainly in the guidelines it would be chemo or RP. I think most patients, when you have the discussion, will choose the RP. I think this is one, based upon the piece 3, you could actually think about enzalutamide plus radium-223.
Yeah.
We certainly have a discussion with that. That's happy to have the fight with the insurance company. I'm not sure it's quite in the guidelines yet, but just assuming you are cash pay and things. Yeah. I think that's intriguing. Certainly would want to do genetic testing and see, and I see the second cases could have gotten into that. So let's say we do the testing and he's wild type,
yeah.
Right? We don't have FDA indication for combination with PARP. So to me, it would be an RP and then think about adding radium.
And you'd add a bone protective agent.
Absolutely.
For sure. That was one of the real early takeaways from piece 3. These patients need to be on it.
Absolutely.
Even if, yeah, that's key. And exercise, vitamin D, calcium supplement.
Sure.
Okay, so quick question, Eleni. Steve gets a germline test on this patient. It's negative. Is that it? Do we stop there? Do we get
No,
somatic? Or
well,
not?
I was thinking as you were talking, and I was like, I'll get somatic, and I'll actually make it a little harder on us. It comes back with an ATM mutation, right? The one mutation that we haven't seen the greatest
But I
data.
was going with the fact that you've got to get somatic.
gotta
'cause
get
if
it. You
don't-
gotta
If
get
you
it.
stop at germline, you'll miss 50% of the HR
Oh, yeah.
mutations.
Absolutely.
That's really important take home there. All right, now for you, Eleni, on this one. Carson, he's 67, MCRPC. His sister had breast cancer. He's got a BRCA mutation because his sister was tested and he went and he got tested. So that's the beauty of cascade family testing, which I think people really need to appreciate. You can help somebody's family member pick up their ovarian, their breast, their pancreatic, their colorectal cancer. You may never hear about it, but you're saving that patient's life by getting them detected earlier when they're localized as opposed to metastatic. All right,
You? Me?
all right, so somebody in the audience is tweaking my mic. I don't know. All right, so this patient, he's BRCA2, and he has prior treatment for MHSPC, he had ADT and ABI, and now MCRPC. What do you talk about?
This patient is going to get a PARP inhibitor plus the ARPI, 100%.
Yeah.
And this is the difference between life and death. I don't mean to be dramatic,
Yeah.
but all the data is saying you're changing the projection of the survival of this person and their livelihood. Sure, it's still metastatic, I get it. But we have people who have lived now 4 or 5 years on these combinations. We've treated them. It's very important that you consider that.
Absolutely. So this is an example of intensification that's personalized and precision-based, it's genetic-based. And to miss this opportunity based on the TALAPRO-2 data would be just a terrible. All right, so Zero has got wonderful downloadable resources for you and support for your clinic and for your patients, so please use that. All right, now, here's your opportunity to click to see if you've won. If you see the green winner message on your mobile device, please see the peer review folks in the back, and you can claim your prize. Are we going to see this wheel spin? I don't think so. It's what? Oh, okay. All right, but look on your phone. Do we have anybody who's a winner? Whoa!
Woohoo!
Yeah.
I should give it to you in chips.
Congratulations. I think there's a few winners. It's more than one. And if nobody
should
else
be.
claims, then you get all of the prizes. I just made that up. I don't know. All right. You can get all the slides that we have here. It's a lot of great content. I think, and we really want your feedback. So folks virtually, folks all in the room, thank you so much. I think that was it. Have a great AUA and good luck at the casino. Thanks so much for attending.
Thank you. It was fun.